Good afternoon, and thank you all for joining us. And a special thank you to Dr. Thomas Serena for being here to present today. He'll be presenting on, I'm excited about this title, a report card on U.S. antimicrobial prescribing practices in wound care, a failing grade. Sounds ominous. After his presentation, there will be a Q&A. So please, if you have any questions, find the chat icon in this Zoom call and you can put any questions there and we'll go through them at the end of the session and get through as many as we can. So now I'm delighted to turn this over to Dr. Thomas Serena, the founder and medical director of the SerenaGroup Research Foundation. Thank you so much, Dr. Serena, for being here with us today.
Thank you, Monique. And it is a provocative title, but unfortunately, it's really true. The truth of the matter is, and you'll hear in the next 12 minutes or so, that as far as antibiotic stewardship is concerned and the use of antibiotics and antimicrobials in wound care, it is a failing grade that our wound care centers would receive. At the same time that we are looking to institute antimicrobial stewardship on an outpatient basis, we find ourselves unable to do so because of the lack of diagnostics until now. So let's go ahead and get started. Next slide. So how do we decide what to prescribe? So we have we got microbiology analysis cultures that we do in the wound center. Well, I'll be happy to send you the recent paper that Greg Schultz and Phil Bowler and I just published, demonstrating that the cultures that you use in your center are incredibly inaccurate. Certainly couldn't build an antibiotic stewardship program based on that. And an assessment of clinical signs and symptoms is the primary way that most physicians at point of care are making their decisions on what to prescribe, whether it's antibiotics, antimicrobials, or antiseptics. So it's just based on this. Now, the nice thing about this is it's point of care. The bad thing about it, as we'll show you in a minute, is that your clinical signs and symptoms, the sensitivity is incredibly low. Next slide. So you can see this whisker plot that, first of all, bacteria have a lot of wounds. Now, what we're measuring here is wounds we're detecting wounds greater than 10 to the 4th CFU per gram. And that's 82% of the wounds in this large clinical trial, 350 patients that was done in 2018, 2019. And what you see is that based on clinical signs and symptoms alone, only 15% of the wounds that had significant levels of bacteria were detected. Really not very good. Again, clinical signs and symptoms are just simply not very sensitive to clinical signs and symptoms. And this makes sense, right? If you've been in the wound clinic a long time, you know this is true. You look at the patient and say, oh, is that infected or is it not infected? It's really difficult to tell. And this is something we've been struggling at for a long time. I think finally we're getting some answers. Let's go to the next slide. So the FLAG trial was the large multi-center clinical trial that I mentioned before. And let me go through how it was done. So what we did first, step one is that the clinician, 20 investigators across the United States, looked at the wound and they graded it based on the clinical signs and symptoms of infection. We used the International Wound Institute guidelines for clinical signs and symptoms. If there were 3 or more or 1 predominant, then the clinician would say, yes, that wound has positive for clinical signs and symptoms. If it didn't, it was less than 3, then the clinician would say it was negative. Now, based on that, we would go to a treatment plan. And so before we did anything else in the study, the clinicians would go out and they would fill in what they were going to do. It's basically an order form for that patient based on what they'd seen. The next step was to do a wound culture and microbiological analysis, as well as fluorescence imaging. And we were able to tell exactly what was there and how good we really are at clinical signs and symptoms of infection. As I said before, not very good. Next slide. So this is the FLAG trial. I mentioned 350 patients with chronic wounds of all types. This is a very real world study. We had 2 exclusion and 2 inclusion criteria. This is your patient population. This is a real world clinical trial. It's the best of both worlds. It's a randomized clinical trial, and at the same time, it's also a real world study. I wish I could do all my studies like this. 20 clinics, clinicians, 14 outpatient clinics spread across the United States. We had a variety of clinical specialties involved: podiatrists, wound care physicians, nurse practitioners, and a variety of wound types. The majority of the wounds were diabetic foot ulcers, and venous leg ulcers, pressure ulcers, surgical wounds were well represented. And it's interesting because there weren't a lot of difference between the practitioners, weren't a lot of differences in detecting infection with clinical signs and symptoms at the sites or based on the type of wounds. In fact, the worst of these wounds, surprisingly, were the surgical wounds. They were the hardest to detect any types of bacterial load. Next slide. So when you look at that, antimicrobials prescribing at present, based on this study that was just published last week, and I'm glad to send you a copy of it if you want one, because it's really going to be a pivotal paper. What you see here is that if you look at all bacterial loads, no matter what you had, whether you got antimicrobials or not, it didn't really matter if you were positive or negative on clinical signs. You were just as likely to get antimicrobials if your clinical signs and symptoms positive or clinical signs and symptoms negative. Now, this may also speak to the fact that we realize that we're not very good with clinical signs and symptoms. That may be part of the whole issue. So, well, you find that, and I think there's one more piece on this. Go ahead, Anna. Yes. So, if you look at wounds at less than 10 to the fourth, so clearly that level of bacteria is not going to inhibit wound healing. Those patients do not need antimicrobials. But look at the number. But look, we have 100% of the patients that had clinical signs and symptoms positive but didn't have bacterial loads got antimicrobials, and those that were negative, almost 90%. This is antimicrobial misuse. I don't know a nicer way to put this, but this is your failing grade. I'm sorry, this includes me as well, but we all get an F. This is just simply not working. And then look at the next bars, greater than 10 to the eighth. So if these are wounds that are floridly with bacteria, I would call these wounds clearly infected. And if you look at Marty Robson's data, that's 100% true. And you see that in that group, there's still a large percentage. There's only 2/3 of them got antimicrobials. What happened to the other third? They didn't receive it. You can see our grading is not getting a whole lot better here. As more and more we look at this data and dig into this extraordinary large database, the use of antimicrobials, antiseptics, antibiotics in the wound care center is haphazard and not guided by clinical evidence. Next slide. So what we looked at there was antimicrobials. I'm going to switch now to antibiotics. So antimicrobials could be antimicrobial dressings or topical antiseptics. And that's the way we analyzed it when we did the trial. But let's look specifically at antibiotics, and you look at all bacterial loads. And again, what you see, a significantly higher proportion of clinical sign symptom positive wounds were prescribed antibiotics. So that's at least a bit of a positive there. Go next slide. But 75% of the patients who didn't have any, when you do quantitative biopsies, had no bacterial load or low bacterial load, certainly didn't need antibiotics, got antibiotics. If they thought they might be positive, they got an antibiotic. Even if you thought they were not negative, so 42%. Okay, let's go back to it again. This is not just antimicrobials. You might say, oh, Tom, don't worry about it. It's antimicrobials. We're not worried about it. It's not just antimicrobials. It is antibiotics. And our goal, Joint Commission, if you're in the US, Joint Commission has stated that we need to develop an antibiotic stewardship program for the wound clinic. How are you going to do that based on clinical signs and symptoms? Not possible. It's simply not possible. Here you are over-prescribing and under-prescribing. If you look at the greater than 10 to the eighth, now you see that we have a large proportion of patients that are not getting antibiotics who perhaps should at least get antimicrobials, but and some of these patients at these very high levels should have been getting antibiotics as well. Again, I'm going to repeat myself. It's haphazard. Next slide. So why is antibiotic stewardship such a challenge? Well, there's an under appreciation of the severity and prevalence of bacterial wounds. I just showed you earlier that 80+% of patients that walk into your wound clinic have got greater than 10 to the fourth bacteria in the wounds. We don't know, we don't realize it because we can't see the signs and symptoms that we rely on with our clinical examination. Then we tend to underestimate or underappreciate the amount of bacteria that are present in the wound. Again, there's a lack of universally accepted standard for diagnosing infection chronic wounds. Try to define infection and chronic wounds. I know a lot of groups are undertaking that, and God bless them. That's a great undertaking. But it really is difficult. And there's a lack of real-time information. As I said previously, your swabs aren't that accurate, and even if they were, it takes 3 days to get them back, and that's really not a very acceptable way to do things. I need to know now. Yeah. So how do we fix this immediately? I think we make fluorescence imaging a routine part of your wound care. And this is what we've been talking about here at the booth all morning. This is fluorescence imaging. You see the red color, that is most of the bacteria in the wound. And then unique to Pseudomonas is the cyan color in the bottom image. This allows you to make a point of care diagnosis. I will tell you, in the FLAG clinical trial, the positive predictive value neared 100%. Very, very accurate. And as you get better at it, as you do more and more images, your ability to detect clinically significant bacteria increases. Next slide. So there's been evidence that already that's been done out of the UK in the NHS. Now, those of you who know the NHS know that they are a frugal group, to say the least. And they have embraced this MolecuLight technology. But why? Because they saw a 33% reduction in antibiotic prescribing. There's a 49% reduction in antimicrobial prescriptions. They're saving money and improving patient care. And when you combine that with some of the other studies that have been done, such as by Alicia Arapalo and Wendy Cole, we see a twofold increase in the 12-week healing rates. And you see a switch to healing trajectory without the use of antibiotics. The wounds start healing without the need for antibiotics if you don't need them. We want to use antimicrobials and antibiotics when we need them. We don't want to use them when we don't want to use them when we don't need them, because they're going to be harmful. Certainly, we're going to breed resistant bacteria. We need a diagnostic. It needs to be point of care. And now in 2021, that is available. You have the MolecuLight device. And I will tell you personally, I own 22 of these devices. Pretty much we plan to put one in every single one of our clinics, and hopefully we'll achieve that by December 31st of 2021. Next slide. So key points, takeaway, as we're getting towards the end of this: the prevalence of problematic bacterial burden in wounds is vastly underappreciated. I can't say that enough. Again, 85% of wounds have a wound and bacterial levels that are at a point where they're going to impede wound healing. There is a rampant over and under prescribing of antimicrobials. And as I said before, this is worse than flipping a coin. Whether you get antimicrobials, antiseptics, it almost depends, on the weather. So antimicrobial stewardship efforts will fail without an objective point of care. I don't know how you're going to institute Joint Commission's program for antibiotic stewardship if you don't have a diagnostic that is A, point of care, and B, accurate in diagnosing bacteria at a clinically significant level. So as I said before, in our clinics, our goal is to have this device in every clinic of ours. And I think we're going to achieve it. We're well on the way there. Certainly in the research clinics, that's already been achieved. We have one in every research clinic, and soon to have one in every one of our clinics, both our HOPDs and private wound care centers. So, next slide. I didn't leave much time for questions, but we'll zip through a few if we can.
Thank you so much, Dr. Serena. This feels like a pivotal data point for the field of wound care to really understand how problematic the situation truly is. So congratulations on this body of work.
Thank you. Well, it is a pivotal moment, and it's something we've suspected for a few years. And I remember having discussions about it with folks, but I didn't realize it was this bad. I mean, this was surprising to me. And look, I'm in every one of those databases. That includes me too. So
I wondered, and if anyone has questions, please put them in the chat of the bottom of your call. But I have a few. So to start off, what do you think? This was in the outpatient setting. what do you think might be happening in long-term care facilities, where my understanding is antibiotic usage higher than the outpatient side?
I think this goes to home health and to our skilled nursing facilities and other long-term care facilities. Boy, it's going to be worse there. By far, right? Because you don't have as much access to wound care and to debridement, and certainly I don't do as much debridement in a skilled nursing facility as I would do in my wound clinic. That's for sure. So I think you're going to see this as a much greater problem, and it's nice to see some folks like Martha Kelso and others who are adopting this in those settings.
And in your settings, and you've adopted this technology, have you seen any changes in your antibiotic prescribing rates? Have they gone down since implementing this?
So we're just in the process of implementing and gathering that data, and already what we've seen is a decrease in antimicrobial use. And we haven't analyzed the antibiotic data yet, but certainly I can tell you that we're seeing signs. For example, culturing has gone. Both molecular culturing and regular swab culturing has dropped into the basement. So we're doing a lot less of that. And I suspect that we're also going to see a fall in antibiotics and antimicrobials next year in the next WoundCon. By then we'll have some good data. All of our centers are reporting this as part of the antimicrobial stewardship requirement.
Right. Well, I thank you for presenting this. This is just such important data to get out for the world. And so I appreciate your time today, Dr. Serena, and everyone else. Thank you for joining, and enjoy the rest of your time at WoundCon.
Enjoy WoundCon. Thank you.
Thank you.